Thank you. At the onset, I would like to thank AIOS, the scientific committee, and more thanks to Harshadhan Ghorpade. So, though I'm talking about it, I've kept his name as first for the simple reason that the picture demonstrates my life. So, that's Sunil Murikar, who goes below the surface and gets into trouble many times. And that's Harshan Gode, who skims on the top and flies and is flying high without having any problem. So I think my first slide is revealing what I'm going to talk about. So conflict of interest, none. The objectives, the participants at the end of the presentations will be able to state which two groups of patients can undergo surface ablation safely when LASIK is contraindicated. State the time duration of recovery of best corrected acuity of both procedures, how many years it takes for the subcorneal nerves to recover after both procedures, and a couple of other things as well. But I have kept the objectives few. So in terms of safety, let's look at the indication safety. So surface ablation allows the surgeon to treat patients with thin corneas and higher errors who might be contraindicated for LASIK. So these are the two references I was speaking about. And the AAO refractive management intervention preferred practice panel, they talk about myopia less than 14 for surface ablations and up to 12 for LASIK, and hyperopia up to 5 with 3 diopters, and mixed astigmatism can also probably be corrected by surface ablations. So what happens to the best corrected visual acuity when you look at surface ablations versus LASIK? So myopia, when it is corrected with PRK, shows better acuity, and PRK is better in terms of efficacy than LASIK for myopia after 4 years. So look at that graph. The time course of the average and 95% intervals, confidence intervals of best corrected visual acuity in the laser in situ group, which is a closed square. So these are the closed squares versus the PRK, that is the open square circle, right? So what you see here in the graph is initially you have a better correction, and then in LASIK, in PRK the initial correction is not so great, but at 4 years and 10 years also sometimes, you will see that the PRK does better. The predictability studies. What is the predictability? I mean, you think that you're going to get a minus 0.5 or a plus 0.5, or you have aimed for a particular correction. So the predictability of refraction and the percentage of the target refraction, so the percentage of patients who reach the target refraction of plus or minus 0.5 diopters in a 12-month follow-up are better and comparable in trans PRK for both myopia and high myopic groups. So there are 4 studies which have done this. So when you do a review, you realize that many studies are talking about PRK being better in terms of predictability. So you aimed for a 0.5, you get 0.5. You don't get surprises. Then comes my favorite topic, the recovery of the subcorneal subbasal nerve density after PRK and LASIK. So we do a lot of corneal reinnervation surgery. We take the sural nerve and connect it to the supraorbital, supratrochlear, and into the cornea. And there are many cases in which we have a corneal opacity, and you return the corneal innervation, and you realize that the opacity sometimes reduces in size. Corneal grafts sometimes don't do well if the corneal innervation is not good. So the stemness of the stem cells in the cornea are dependent on corneal innervation. So if the corneal innervation is not good, the stem cells will simply not function like a stem cell. So what happens to corneal subbasal nerve density? It does not recover to near preoperative densities until 5 years when it comes to LASIK, as compared to 2 years after PRK. So that's the graph which shows up to 5 years. That's PRK, and this is LASIK. So you see the difference between the two. Corneal sensitivity, because the nerves are less. So we do an analysis of the nerves in many of our patients, confocal, and with many other devices, and we realize that the nerves are less, especially a lot of patients have already undergone procedures. Some of them come to me with diabetic corneal sensations reduction, diabetic neurokeratopathy. Some diabetics who have undergone a LASIK or a PRK in one eye will have a lesser density in that eye compared to the other eye. So uniocular myopes who are diabetic. So then people come and tell me this is because of diabetes, this is diabetic corneal nerve loss. But no, diabetics, it's worse when you have done a LASIK, compared to the diabetic in which you've done the PRK, especially in uniocular myopes, when you see that the other eye has not been operated. So it's not diabetes, it's got to do with something. So I'm already a little, it's like being hit by COVID. I'm already a little weak and you hit me with COVID, I will be worse. I'm healthy, you hit me with COVID, nothing may happen. I'm healthy, you hit me with LASIK, nothing will happen. I'm not healthy, diabetic, you hit me with LASIK, I might have a problem. Might, not will. So then the other things, the nerve fiber density, the branch density. So you don't look just at the nerves, you look at the nerve fiber density, how many nerves per square centimeters or per square millimeters, branch density and fiber length. What is the length of the fiber? Does it go right up to the center? So some nerves they regenerate and they just fall short of the center, whereas in PRK they go right up to the center. So looking at the nerve density, you look at nerve fiber density, LASIK, pre-op, these are comparable values. So there are times when people tell me many of the data which I look at, people tell me what is a post-op comparison, but have you compared it pre-op? The pre-op demographics and the statistics should be comparable. You didn't start off with a group which was already very bad, right? So you look at the nerve fiber density, pre-LASIK versus LASIK, and the p-value is significant. Post-op 1 month, 3 months, 6 months, no branch density, no fiber length, everything, the story is the same everywhere. Dry eye. So obviously if you have a lower corneal nerve sensitivity, the dry eye is going to be worse. So if there's no sensation, there's no input or an afferent which says that the surface is dry, there is not going to be an efferent. So the watering is not going to be there. Reflex watering is going to be poor, right? So a surface approach also causes less tendency towards dry eye in patients with borderline tear film. So there are some cases in which there is already a borderline tear film deficiency, and some of them are computer vision syndrome. Sometimes they are not computer vision syndromes but also have a borderline tear film deficiency. Some of them are pre-rheumatoid, family history of rheumatoid arthritis. So these are borderline cases. So you look at the tear film breakup time in LASIK, the pre-operative, post-operative, and this thing, and you look at it after and look at the Shermer's test between LASIK and the PRK. Both of them are better. What about ectasia? We all know that because the corneas are surface ablated, the residual cornea is going to be thicker. So a thicker cornea is less likely to become ectatic. So there is a less risk of ectasia. This is the reference. There is increased preference of surface ablation over laser in situ between 2008 to 11, and that is correlated to the risk of ectasia. So this has come out of Auckland. And you also look at the EFRSS score, the ectasia risk factor score system, and you will realize that between surface ablation and LASIK, we are much better off with surface ablations. And obviously you don't have flaps. So with LASIK, there are flaps, and flaps have complications, and there are very dangerous complications. Some of the times the flap opens up, some of the times the flap is lost after some time. There is interphase sands sometimes. Then there is an issue of glaucoma. So when you use the suction cup, and I'm not very sure whether this is true because there are very few reports in literature, but all the places where I have worked and I have a LASIK, I do a contact, non-contact with LASIK flaps. You have to be very careful when you do the gonioscopy. Many people don't do the gonioscopy. I do the gonioscopy without, I'll use an 8 mirror, I will not turn the gonioscope. And when I look at it pre-operatively, there are many of these patients where I have done the gonioscopy for a glaucoma evaluation pre-operatively, and the same patient has come to me post-operatively. I will see a angle recession in many of the cases in which a suction ring has been used. So there are very few case reports. Nobody has studied this so far. It has been my fault that I have not published these cases. But I have a series of patients in which you see an angle recession. And there is also a risk of retinal detachment because you're using a suction cup, and you may have an issue there. What in terms of corneal biomechanics? So when patients come to me for glaucoma evaluation post LASIK, or for that matter for glaucoma evaluation in any case, the most important thing is the corneal biomechanics. Is that how is the eyeball? Is it like a rubber ball? Is it like a tennis ball? Is it like a season ball? How much will it bend? how much is the expansibility. So there are variations in intraocular pressure, and if my balloon expands, the thin retinal nerve fiber layer inside is not pressed. So it's like me in a train, and if I am a fat man and somebody comes, my tummy can be pressed in, I won't die. Versus, and the walls are pliable. But if the walls are not pliable and suddenly there's a rush inside, I will get pressed against the wall and I'll die. So corneal biomechanics is important in that sense. So I take a ball and I bounce it, and it bounces very high, which means it is very elastic. It can expand. So the death of an RNFL in terms of fluctuations of IOP is less likely. But if it's an unforgiving ball, it does not expand. A fluctuation of IOP will cause loss of RNFL. So what happens to the corneal biomechanics after you do a LASIK versus after you do a PRK? So when you're opening and cutting up a eyeball and raising a flap, obviously your corneal biomechanics are going to be disturbed. Versus when you're not raising a flap, the corneal biomechanics are not going to be disturbed. My evaluation of whether this patient is going to get a glaucoma or not have a glaucoma has a very important factor of corneal hysteresis, which we see with the corneal ocular response analyzer. This goes totally caput if a LASIK has been done. If a PRK has been done, the values are similar to pre-op corneal hysteresis, right? So PRK has the least impairment in biomechanical because there's only surface ablation. So that's comparing all of them. So the indications, the refraction corrections, globe contact, platform. Globe contact, I would like to say more because you're using something again and again. We have a propensity to reuse instruments, and post-COVID era, probably this is another thing that might be worth considering. The eye tracking systems and all of them are similar, but biostability is the strongest with trans PRK, whereas it's not so with. There are other advantages: thin corneas, epithelial membrane disease, and subtle corneal irregularities. Thank you. So I would ask you at the end of it, would you want to be Harshvardhan Ghorpade with a surface, or would you want to be Sunil Marikar with a LASIK? I think the answer